Margaret is 67 years old. She spends most of her summer afternoons in her garden. She has 2 dogs. She has a husband who tells her she worries too much and a daughter who calls every Sunday. She is healthy by any measure she has ever been given. Blood pressure a little high, some stiffness in her knees, nothing dramatic, nothing alarming. In July, she notices a small raised lump on the back of her upper arm. It is about the size of a large grape. The skin over it looks normal. It does not hurt. She presses it with her finger, and it is firm, smooth, and completely painless. Her husband says it is probably just a cyst. Her daughter says to put some antiseptic cream on it and see if it goes away. Margaret agrees with both of them. She does nothing. She does absolutely nothing about the lump. 3 months later, the lump is still there, slightly larger but still painless. And then something happens that she mentions only to her husband in a low voice, as though she is embarrassed to say it out loud. Sometimes, she says, it feels like there is something moving inside it. A faint pulse, a flutter almost. Her husband tells her she is imagining things. She probably is, they agree. It does not hurt. She has more important things to worry about. 6 months after that, she notices a tiny opening at the very top of the lump. A hole, barely visible, like a pinprick. The lump almost seems to be breathing. She looks up her symptoms online and reads about infected sebaceous cysts. She applies antiseptic and covers it with a bandage. She makes a mental note to mention it at her next physical, which is in 4 months. She does not mention it at her next physical because she forgets. 2 years after she first noticed the lump, she goes to her doctor for an unrelated reason. Her blood pressure medication needs adjusting. Her doctor notices the lump during the examination and stops. He looks at it for a moment without speaking. Then he refers her immediately to a dermatologist. The dermatologist takes one look and refers her directly to surgery. What the surgeon found when he made his incision, what had been living inside Margaret's arm for 2 full years, feeding quietly, breathing through that tiny hole in her skin, made him call 2 colleagues into the operating room to see it before he removed it. I am going to tell you exactly what it was. I am going to explain how it got there, why Margaret was at higher risk than she realized, and why her immune system produced almost no warning for 2 years. And I am going to give you the specific signs you need to watch for, the exact questions to ask your physician, and the blood tests that should be ordered if you or someone you love has ever had a lump dismissed as nothing. My name is Dr. Whitfield. I have spent over 20 years in internal medicine and longevity medicine. And what I am about to tell you is something that the medical establishment in Western countries dramatically underestimates, systematically underdiagnoses, and almost never discusses with patients over 65. Stay with me for the next 23 minutes. You are going to want to hear this. Before we go any further, where are you watching from today? Drop your city or country in the comments. I read all of them, and I genuinely want to know who I am talking with. Now, let me tell you what was inside Margaret's arm. The surgeon made a careful incision along the length of the lump. What he encountered was not the fluid-filled sac of a benign sebaceous cyst. Inside the cavity was a living organism, a botfly larva, approximately 2 centimeters in length, with a ringed segmented body and small hooks at its anterior end that had been anchoring it in the subcutaneous tissue. It was alive. It was moving. The tiny hole at the surface of Margaret's skin, the one she had noticed and covered with bandages, was the breathing pore through which it had been exchanging oxygen with the outside world for all this time. The condition is called cutaneous myiasis. And I need you to understand something before I explain the mechanism. This is not a disease of poverty. It is not a disease of poor hygiene. It is not limited to travelers who visit tropical countries, and it is not rare in the way that most people assume. It is simply underreported, underrecognized, and almost never considered in the differential diagnosis of a skin lump in an older adult in a Western country. That gap between how common it actually is and how rarely it is considered is what allowed Margaret to go 2 years. Let me explain exactly how this happens. Certain species of flies are capable of depositing eggs on or near a human host. The human botfly, Dermatobia hominis, is native to Central and South America, and has been documented with increasing frequency in returning travelers across North America and Europe. But it is not the only species. Several blowfly species, including Wolfardia magnifica in Europe and the Middle East, and Cochleomya hominivorax in parts of the Americas, are capable of depositing eggs directly on human skin, particularly near hair follicles, minor abrasions, or areas of compromised skin integrity. The eggs hatch within hours. The first stage larvae are extraordinarily small, small enough to enter through a pore or a hair follicle without causing any sensation whatsoever. Once beneath the surface of the skin, the larva establishes itself in the subcutaneous fatty layer and begins to feed. It does not damage major blood vessels or nerves. It does not produce the enzymes that would cause severe pain. It grows slowly. It maintains its breathing pore. And in most cases, in the absence of a vigorous immune response, it produces very little local reaction. In a healthy person in their 30s or 40s, this would typically cause significant inflammation, redness, warmth, intense itching, sometimes a throbbing pain, that would drive them to a physician well within weeks. The immune system recognizes the foreign organism, identifies it as a threat, and mobilizes an aggressive response. The response itself is what produces the symptoms, and the symptoms are what bring the person to care. Here is what changed for Margaret. There is a phenomenon in the field of gerontology called immunosenescence. It refers to the gradual, cumulative decline in immune function that occurs naturally with aging. The immune system becomes slower to recognize foreign antigens. It becomes less efficient at coordinating inflammatory responses. The communication between immune cells, the cascade of signaling molecules that normally produces the redness, the heat, the pain that tells you something is wrong, becomes blunted, not absent, blunted. In practical terms, this means that an older adult can be harboring an active infection, an active infestation, an active pathological process inside their body, and their immune system will produce a warning signal that is too quiet for them to notice. This is why older adults so frequently present to emergency departments with sepsis from infections that should have declared themselves days earlier. It is why pneumonia in an 80-year-old sometimes presents with nothing more than mild confusion. And it is why a bot fly larva lived inside Margaret's arm for 2 years while she felt almost nothing. There is a second layer to this. Many adults over 65 are taking medications that further suppress immune signaling. Corticosteroids are prescribed for arthritis, asthma, inflammatory bowel disease, and many other conditions directly suppress the inflammatory response. Methotrexate and other disease-modifying anti-rheumatic drugs do the same. Even long-term high-dose non-steroidal anti-inflammatory medications reduce the local inflammatory response that would otherwise bring something like this to attention. If you are on any of these medications, your baseline immune alarm system is already operating at reduced capacity. And there's a third factor that is specific to older skin. The dermis thins with age. Blood flow to the skin decreases. The skin's barrier function, its ability to block external organisms from penetrating, weakens. Wounds heal more slowly. Minor abrasions that would close within hours in a younger person remain open longer. This creates a window of entry that is simply wider in older skin than in younger skin. Immunosenescence, medication-induced immune suppression, reduced skin barrier function. All three were present in Margaret. All three contributed to 2 years of silence. Now I want to broaden this conversation because the botfly is the most dramatic example of what I am describing, but it is not the most common. There is a spectrum of organisms capable of establishing themselves inside the human body, particularly in older adults, that are systematically underdiagnosed in Western medicine. And I want you to know about each of them. The first is Toxocara canis and Toxocara cati, the roundworms of dogs and cats. This will be uncomfortable for pet owners, and I need you to stay with me through it. The adult worms live in the intestines of infected dogs and cats. They shed microscopic eggs into the environment through feces. Those eggs persist in soil for months to years. They are present in soil in backyards, in parks, in community gardens across North America, Europe, and every temperate climate on Earth. When a human being, typically through unwashed hands after gardening, through contact with contaminated soil, or through ingestion of unwashed vegetables grown in contaminated ground, accidentally ingests these eggs, the larvae hatch in the human intestine, penetrate the gut wall, and migrate through the body. The human being is not the intended host. The larvae cannot complete their life cycle in a human. What they do instead is migrate to the liver, the lungs, the muscles, the eyes, the brain, where the immune system eventually walls them off in small granulomatous lesions. In most cases, people never know this happened. The lesions are calcified, silent, and invisible unless you happen to get an imaging study of that part of the body for another reason. The CDC estimates that 14% of the population of the United States has been infected with Toxocara at some point in their lives. That is not a rare disease. That is 1 in 7 people. And the rate is higher in people who have owned dogs, who garden, or who have lived in rural areas. In a small percentage of cases, the larval migration causes significant illness, inflammation of the liver, pneumonitis, and in the most serious cases, ocular toxocariasis, where a larva migrates into the eye and causes progressive visual loss. This condition is often misdiagnosed as a retinal tumor and has led to unnecessary surgical removal of eyes. It is diagnosed with a simple blood test. The second organism I need you to know about is Echinococcus granulosus, the tapeworm of dogs and livestock. This organism produces what are called hydatid cysts, slow-growing fluid-filled structures that develop in the liver, the lungs, and occasionally other organs after accidental ingestion of tapeworm eggs from contaminated soil or infected animals. These cysts grow at approximately 1 centimeter per year. They are frequently found incidentally on ultrasound or CT imaging, where they are often misidentified as benign liver cysts or simple fluid collections and marked as requiring no follow-up. The reason this matters is twofold. First, hydatid cysts are treatable with antiparasitic medication and, when necessary, surgery. Second, if a cyst ruptures, the fluid it releases can trigger a severe anaphylactic reaction that can be life-threatening. How many older adults in Western countries are walking around with uncharacterized liver cysts that are actually hydatid disease? No one knows, because no one is routinely testing for it. The third organism is Dirofilaria immitis, heartworm. Most people know this as a disease of dogs treated with a monthly preventive medication. What most people do not know is that human infection occurs. It is transmitted by mosquitoes, the same as in dogs. In humans, the larva migrates to the pulmonary circulation, the blood vessels of the lungs, where it dies and produces a small nodular lesion. On a CT scan of the chest, this lesion is indistinguishable from an early-stage lung cancer. Many of these patients undergo invasive biopsy procedures, and some undergo thoracic surgery before the nodule is identified as a parasitic lesion rather than a malignancy. Dirofilaria serology, a simple blood test, could have identified it without surgery. It is not routinely ordered. Now let me give you something you can use. These are the specific symptoms and findings that should prompt you to raise the question of parasitic infection with your physician. A subcutaneous lump or nodule that has been present for more than 6 weeks without resolving, particularly if you spend time outdoors, garden, or have pets. Any lump that is firm, non-tender, and persists. A sensation of movement beneath the skin. I cannot overstate how consistently this symptom is dismissed by clinicians and by patients themselves. It is not your imagination. Subcutaneous movement is a recognized and documented symptom. If you feel this, say it out loud to your doctor in those words. A small punctum, a tiny opening at the apex of a skin nodule. Do not press on this. Do not try to extract whatever is inside. The contents of some of these nodules, if squeezed incorrectly, can cause severe secondary inflammatory reactions. See a physician immediately. Unexplained eosinophilia on a blood count. Eosinophils are a type of white blood cell whose primary function is responding to parasitic infection. When your CBC shows elevated eosinophils and no one can explain why, that is the moment to ask for a parasitic workup. By name. Incidental findings on imaging liver cysts, pulmonary nodules, calcified granulomas, splenic lesions that have been characterized as benign and dismissed without further investigation. The single question that changes everything in these situations is, could this finding be of parasitic origin, and is there a serology test we should order to rule that out? That question costs nothing. The tests it leads to are inexpensive. Now I want to speak directly to the family members and caregivers who are watching, the adult children who come to appointments with parents, the spouses who notice things their partner dismisses. This is how Margaret went 2 years. Older adults have decades of experience being told that what they are feeling is just aging. They have learned to dismiss their own symptoms. They have internalized the message that not wanting to be a burden means not raising concerns that seem minor. You are allowed to bring it up. You are allowed to say to the physician, "My parent has had a lump on their arm for 4 months. They say it doesn't hurt, and I would like it examined today." You are not being difficult. You are doing your job. Let me answer the questions that I know are forming. Is this something I need to be genuinely worried about? I am not telling you this to generate fear. I am telling you this to generate awareness. If I have a dog, should I be worried? Owning a dog does not put you at high risk if your dog is regularly dewormed and if you practice basic hygiene. The risk comes from extended contact with contaminated soil, not from contact with the animal itself. What should I do if I have a lump right now that I have been ignoring? Make an appointment today. Tell your physician that you have a skin nodule that has been present for longer than 6 weeks and that you want it examined and characterized before it is dismissed as benign. The answer to all of these questions is the same. Use your voice, use the vocabulary I have given you, and do not accept dismissal without a specific clinical justification. Let me give you the summary of what matters most from today. Margaret's story illustrates a pattern. The convergence of immunosenescence and medication creates a population that is significantly more vulnerable to parasitic infestation and less likely to produce warning signals. The organisms to be aware of: cutaneous myiasis, Toxocara, echinococcus producing hydatid cysts, and Dirifilaria producing pulmonary nodules, all present in Western countries, all underdiagnosed, all treatable when found. If this video reached you, please hit like. Share it with someone who has a lump they've been meaning to get checked. Subscribe so you don't miss what comes next. Drop a comment with where you're watching from. Next video, I'm going to tell you about the blood test that predicted a stroke in 11 of my patients before a single symptom appeared. It is not on any standard panel. Most internists have never ordered it. You are going to want to know about this one. This is Dr. Whitfield. Know what is in your body because something might be. This video is for educational purposes only and does not constitute medical advice. If you have a skin finding, please consult your physician promptly. The conditions described in this video are treatable when identified. The key is identification.